Thank you, David, and welcome to everybody here from Lisbon to Hamburg. We always have in-person AFNET meetings. So, I was asked to give a sort of a first introductory lecture on integrated care and implementation of integrated care. And the title of this AFNET EHRA meeting is Early Diagnosis and Precision Treatment of Atrial Fibrillation in the digital area. And what does that in fact mean? What do we have to discuss? Well, we have, of course, to diagnose at the first symptoms, but better even before symptoms, and that's why we talk about screening in this first session. But then we have to apply precision medicine, and that means that you need a systematic approach to a patient, otherwise you can never be precise on what that patient needs. So the challenges are in fact that on one hand they are scientifically, we need to find out what needs to be done for individual patients, but I think the other major challenge is how can we apply that to patients, the logistical aspect, which is, I think, much more difficult, honestly. Changing healthcare is a very difficult task. And so if we want to bring precision medicine and early and pre-symptomatic diagnosis to patients, this requires planning, this requires structuring, so that we can include all that is needed for all that are in need. And that's in fact the challenge of implementation. That is integrated care, in my opinion. And the guidelines have stressed the importance, you have seen that, and many hype words are in this nice figure. The problem is that we don't know how to apply. Now, the reason that the guidelines stress this is because of the very nice work done in Maastricht and later in the Netherlands and other places in the world that has shown that if you can apply such an integrated sort of approach, then not only you get better health outcomes, but even you can save some money. And so that is definitely a dominant sort of strategy. The problem is in applying this, and there is no recipe on how to do that. And that, I think, is a struggle for all of us in our own environments on how we can do that. And that was nicely shown, for instance, the RACE4 trial, which built upon the Maastricht experience, and Michiel Rienstar here, and Isabel is there online. And the RACE4 trial at the end did not show positive outcomes statistically, but strange enough, there was inconsistency among centers that were more experienced and centers that were less experienced in having such a structured approach, whatever that may be. And I think that even for the investigators, it was still a bit unclear on what makes the difference, because theoretically, everyone knows what should have been done, and nevertheless, it doesn't show in all centers in the same way. And I think that is the challenge when we talk about implementation of integrated care. Now, EHRA and AFNET have tried to contribute in this field over the years. The STEER AF project was an EHRA project together with Paulus when he was in the ESC education and the Council of Stroke. And we did a first needs assessment study where we try to find out where are the barriers for implementing this sort of integrated AF care. And I will not go over the key findings at the right side, but they include difficulties in detecting atrial fibrillation, which you can see here, uncertainty in making therapeutic decisions, and suboptimal collaboration between specialties and GPs, for instance. Now, the STEER AF project is moving into a second phase with a lot of hurdles, COVID being one of them, but Isabel van Gelder, again, together with Deepak Kotecha, are pushing through, and there will be a second phase where a systematic approach in centers with educating of the healthcare workers will be applied, and we will hopefully see that there is impact on how AF patients are managed. Also on the screening side, EHRA is involved in the AFFECT EU Horizon 2020 project, which is coordinated here by Renate Schnabel and Daniel Engler from Hamburg. In AFFECT EU, there is different work packages that try to define a digital risk-based screening for AF European-wide. ESC, again, and EHRA have the lead in a work package here, work package 5, which goes way beyond the classical dissemination and education activities. There's also scientific activities. And for instance, in this AFFECT EU, there's also a survey of policymakers and professionals done in the first place, where we have tried to find out where do you perceive hurdles on applying a screening strategy for AF, and we have proposed and discussed different scenarios: opportunistic single time point, opportunistic with a patch, longer duration, maybe systematic screening of specific groups, or even patient-led approaches with consumer devices. So we discussed that with a number of people. Again, we had some findings that have been presented at the ESC Congress by Daniel and will be published soon, like the question for more evidence around screening. We will discuss that immediately. The workload this may pose on primary care physicians, the fact that they are not optimally trained to read ECGs and single lead ECGs. So from that qualitative survey, we have now done a quantitative survey, which is still ongoing, and where we ask GPs, if this would be applied in your setting, would you be able to do it? And what are you perceiving as the possible hurdles? What do we need to change to make this happen? This is ongoing and I think is very important information. And we have seen yesterday some preliminary data that are really intriguing when you listen to GPs. Now, coming to the integrated approach, just a very quick sidestep to our own experience and the way we try to tackle this in our institution. Lien de Stegen, who is here today, has developed a questionnaire which is called the JACC and validated in many hundred patients with atrial fibrillation, where we try to involve the patients by knowing their knowledge about their disease and about the treatment. And interestingly, the JACC has been licensed and is in use from Alaska to Beijing, as you can see in many, many centers around the world. And this JACC has taught us that we can start from the knowledge aspect and discuss that with the patient, and from there venture into risk factor management, improving self-care, even including telemonitoring some patients and addressing the whole comorbidity spectrum that these patients have. Now, we also developed an own app like Paulus did with the Catch Me consortium, where ESC was also involved, because we feel that this sort of tools is needed to have that continuous communication with the patient, to involve the patient in that integrated management. And we have recruited almost 1,300 AF patients in Belgium now in an RCT that is looking whether this approach can have an impact on heart outcomes like hospitalizations and other aspects. That brings me to the very last part, which is that, of course, we realize this comorbidity profile in AF is there per definition. AF, in fact, is just an expression of comorbidities, and patients over 65 with AF have on average 5 comorbidities. So it's a challenge to have that precision medicine to find out which are the comorbidities in a specific patient and how can I address those. And for this reason, and based on the experience that the Groningen team had, the Maastricht team had, that we had in Antwerp, we have compiled another Horizon 2020 project, which is called EHRA Paths, which is innovative in 2 aspects. We were successful in getting this grant from the first submission. That is that EHRA and ESC are the coordinators of this scientific project, which is really a new role for EHRA and ESC. But second, that we have involved not only 13 cardiology departments throughout Europe, but each of them has also another department linked into that project: pneumology, GPs, name it, you find them here on the slide. And that's a very original approach, where in 5 years we will try to develop a tool, an electronic tool, which I insist always on all the partners should be minimalistic, but should allow to map every new AF patient and to find out which are the comorbidities, and then make sure that these comorbidities are addressed in a systematic way. And at the end, this approach will be tested in a clinical trial coordinated by Groningen, by Michiel, and by Isabel, where we will not look at outcomes, but where the outcome of the intervention will be, has a comorbidity effectively being addressed according to local practices, because we have to recognize that in different corners of Europe, of course, a same comorbidity may be tackled in a different way. So the outcome is not so important. the fact that the comorbidity is managed, that is what we want to ensure. So this brings me to my conclusion. When we talk about implementing integrated care, management that wants to include all that is needed and to reach all who are in need has to be systematic and integrated. I think you all agree, but the best approach to ensure that sort of systematic management remains unclear. Integrated care definitely requires digital tools, I think, both for the back office in the hospital to get an overview, but also with the patient to involve the patient. And I think AFNET and EHRA are really active partners in the quest for such scalable implementation solutions. And with that, I thank you.